Доброе утро, уважаемые коллеги. Меня зовут Андрей Даду. Я медицинский офицер, работающий в региональном офисе ВОЗ в Копенгагене. Со мной сегодня будет фасилитировать данный вебинар доктор Денис Фальзон, наш коллега, который работает в штаб-квартире ВОЗ в Женеве в глобальной программе борьбы с туберкулезом. Он приурочен к представлению вам одного инструмента. Он называется RD Implementation Research, то есть операционное исследование для применения электронных инструментов по борьбе с туберкулезом. RD4DTB. Этот инструмент будет вам сегодня представлен нашими коллегами, которые из CDR. В том числе и в дополнение к этому мы представим вам еще и те инструменты электронного здравоохранения, которые мы рекомендуем вам их применять. Денис, please go ahead.
Thank you very much, Andre. I hope you can hear me well and see the slide. Okay, thanks very much. So it's always a pleasure to join people from the European region and welcome you to this discussion today, which will take about 2 hours and which will present, I think, some interesting elements and innovations that countries are putting in place. My name is Dennis Falson. For those who have joined now, I'm from the Global TB Program here at WHO in Geneva. Just by way of introductions, we are very pleased to work together with our colleagues in the European region and the Special Program on Tropical Disease Research and Training. We will present some examples of digital technologies. Digital technology applications in TB prevention and care is pretty vast, becoming increasingly large and all pervasive in many of the work that we do today. We are just presenting, as I mentioned, some examples that we wanted to highlight today because of their particular relevance to the European region, their relevance during the pandemic, and hopefully into the recovery period after the COVID-19, the potential for scale-up, and their relevance for implementation research. So these are the reasons why we handpicked some of these technologies today. For those of you who want to follow up the presentations in Russian, you can open the respective presentation in PowerPoint that you have on the shared Dropbox. And if you cannot access that, we can try to send the link again via the chat. So the agenda for today is made of these successive 15-minute sessions. So immediately after our introduction, we will welcome Cecily Miller, my colleague, and Alexander Rastiani to present the use of computer-aided detection software for TB screening in the WHO region. Following which, Georgi Kushovidze from the European region will present about video-supported treatment for TB. Then my colleague Avinash will present on the Prevent TB app for data collection on TB contact and tracing. And then our colleagues from TDR, Vanessa and Corinne, will present about the implementation research toolkit and its relevance to the implementation of digital technologies for TB. Following which there will be a 15-minute time in the end for questions and answer sessions. So just to give a little bit of the brief recent history of digital technologies for TB, this document was produced with the participation of the European Respiratory Society and many other partners, and it set out a draft agenda for how digital technologies can be applied in the during the launch of the End-TB strategy for the post-2015 period. And it proposed some of the key digital interventions that were already being applied at that point or were in the process of becoming available for use in TB programs. And that agenda document proposed this 4-point concept sort of about how we can classify different digital technologies. So there are technologies such that can be used for patient care. We will be seeing, for instance, today, the use of video-supported treatment, which enters into the space of ensuring that people have good communication with their healthcare workers, even when in-person meetings are not possible. Then there's other areas in program management, on management of data, about logistics, etc. There's the whole area of surveillance, right? For collection of data. We will be looking at some of this in the use of the Prevent TB app. And there is also the area of e-learning, so that increased capacity for healthcare workers to acquire new skills or reinforce their knowledge. So many of the digital technologies can fit into more than one of these four areas, so you could have overlap between the different things. And also what we have found during the last 2 years is that many of these use cases that apply for tuberculosis have been also very helpful in the approach and the responses for COVID-19. So if you're talking about video supported treatment, for instance, or other means of communicating with the patient and reminding them about their medication that had applications for COVID-19. Again, management of logistic data has been very important for COVID as well. The use of data for collection of data to understand the progress of the pandemic as it applied in different countries and throughout countries has also had an application, and e-learning, of course, to train people. So a very important, I think, take-home message about the application of the use of digital technologies and TB, learning from that for other conditions. One of the features of the webinar today is to look at scalability, the possibility for an intervention, to expand and to be used beyond a sort of pilot or small study, or but also to integrate it into programmatic work and make sure that it has impact on the global epidemiology. And I'm just showing the trace of incidence as plotted for the NTB strategy with the vision for these 20 years. And of course, we are not where we should be in 2022, according to this graph. So that means that we need to make more progress and especially try and overcome the issues or the problems that held us back from achieving the targets due to the pandemic. I think one document that has shown what countries are doing in these small summaries has been this document that WHO organized and collected. We had 2 versions of it. The last one came out last month, whereby we asked countries to report on innovative interventions that they did to maintain the essential services for TB patients during the pandemic. And you can find the collection of these stories in these 2 documents. But one thing I wanted to highlight here is that in this first column of this table that summarizes the reports, you can see that over half the reports that were given related to one or other aspect of digital health. So I think it's interesting to see as well that digital health feature very high when asking countries to innovate. You can access these documents via the QR codes that's shown in the upper right of the screen. One of the important areas that we will be discussing today in the next presentation, and Cecily will be and Alex will be focused on this, is about the use of computer-aided detection of TB. Last year, in our screening guidelines that you can see here, WHO released its first evidence-based recommendation for the use of computer-aided detection in people with TB who are aged 15 years and older, in which the software can be used in the place of human readers to interpret abnormalities and to decide which persons should go on for further testing. So I think this is a hugely important development. It's, I think, the first WHO evidence-based recommendation relating to a product or a software that is enabled using artificial intelligence. We had before that other evidence-based recommendations on the use of digital technologies to serve adherence support. And the presentation we'll have about video supported treatment, or video observed treatment as we used to call it, is going to focus on that with its specific initiatives that were done in the European region. One thing we want to mention is about, again, the scalability. This is just to show the expansion, which was very rapid and now is very extensive, of video supported treatment for TB patients in Belarus. And you can see over here that immediately following a pilot that was done a few years ago, the country expanded the use of video supported treatment throughout the country using a simple locally developed application for mobile devices. And we have until the beginning of this month, there were over 2,000 patients, half of whom had MDR or XDR TB, in whom VST is being used. Another document that I highlight here is another guidelines that were produced by WHO, by colleagues from outside TB. I point to these guidelines that came out in 2019 because they relate to different steps in the patient pathway, many of which are, of course, extremely relevant to TB as well. And they go beyond the recommendations that we have for TB. So, for instance, about notification of patients and again, the use of telemedicine between healthcare workers, right, which are not captured yet in the TB recommendations. So these have application for TB as well. And finally, I want to highlight the importance of implementation research. Whenever we innovate, we need to collect data. We need to know about what were the barriers to implementation, but also sometimes things which helped the implementation. And I think I will let our colleagues from tropical disease research who are joining us. They are traveling. They're in Africa right now, but they were very keen to join and present today, Corinne and Vanessa, and they will describe how we use this resource, this toolkit that we developed. It is available now both in English and in Russian, and also in French. So this is another resource that we can use. And I use this occasion maybe to highlight as well that we have a training workshop coming up over the week of the 13th of June, so pretty soon, where we will focus about the use of implementation research as it applies for CAD, okay, so computer-aided detection for TB that I just mentioned. Okay, so maybe with that, I will stop here by way of introduction, and I don't know if there are any comments or questions. Thanks very much, Andre, for sending the link to the repository where you can find these PowerPoints and where other background documents will be put in as they come up. Okay, so I don't know if there are any comments or requests for clarification. If not, we can, I think, advance.
No, I'm also monitoring the news. Thank you very much indeed. I'm
Fantastic.
monitoring the chat as well, and just see the greetings from the colleagues who started to interact. And indeed, I believe we should move on and going according to the program with Cecilia and Alexander. Back to you, colleagues.
Okay. Good morning, everyone. Greetings. I'm Cecily Miller from the WHO Global TB Program headquarters as well. I will share my slides. And I will give a brief introduction expanding on what Dennis has just introduced, particularly on the role of TB screening and CAD for TB, and then hand the floor over to Alexander to discuss this further. Can you all see my slides?
Yeah, can you expand it? Can you go up there? Yeah, on the second item. Yeah.
Better?
Yes, excellent. Thanks.
Great.
Hear you very well. Thanks.
Okay, wonderful. So I'll jump in and just start with a brief recap for everyone of TB screening in general and why it is recommended and the role it plays in TB care. So I think we probably all know that TB screening can improve the individual and the community in terms of the TB burden and the TB epidemiology. So TB screening can help bring access to treatment and preventive care to people with TB who might not otherwise reach healthcare, or they might be quite delayed in reaching a diagnosis and starting treatment. So in this way, screening can help reduce delays to diagnosis. It can improve treatment outcomes, and we see evidence that it can reduce costs for patients, particularly reducing the risk of catastrophic costs, which is quite important for the most vulnerable patient groups. And we also see evidence that TB screening helps improve the TB epidemiology at the level of the community. It can, of course, increase the detection of prevalent TB and thereby reduce TB prevalence, reduce transmission, and reduce future incidence of TB. So this is why TB screening can help global TB care by first addressing the case detection gap. As we all know, globally, last year, over 4 million of the estimated incident cases were not diagnosed or notified on treatment. And we know the COVID pandemic has made this global case detection gap even worse. TB screening can also help especially bring healthcare to the most vulnerable groups and populations that otherwise lack access to care. And it's essential before starting TB preventive treatment in populations that are eligible for preventive therapy, which is also a life-saving intervention. So because of these reasons and because of these roles that TB screening plays in global TB care, it's featured in the NTB strategy. We see it here as part in the first mention of pillar 1 of integrated patient-centered care and prevention, includes screening of contacts and high-risk groups. And because of this, the WHO undertook an update of the screening guidelines. And last year, as Dennis mentioned, in early 2021, we released updated and consolidated guidelines on TB screening, as well as an operational handbook that explains more of the on-the-ground logistics and the planning that goes into TB screening. And on the right here, we can see that it's featured in the knowledge sharing platform, which now can be accessed online. So one major part of this guideline was the recommendation of chest X-ray as a screening tool for TB, as well as both in active case finding and community-based screening settings, as well as in clinic-based triage situations. And this is because chest X-ray is a highly sensitive screening tool. So it can detect TB disease early, often prior to the onset of symptoms. And in this way that we can know, we know that it can sometimes reduce transmission. It can improve the efficiency of screening algorithms also as a secondary screen prior to referring people for diagnostic testing, which can be costly. We also see evidence that it can improve the sensitivity of routine screening among people living with HIV, over and beyond detection of prevalent cases that we see from symptom screening alone. And it is a useful tool to rule out TB prior to initiating TB preventive treatment for the same reasons, that it's highly sensitive in detecting active disease. In these screening guidelines, also for the first time, as Dennis mentioned, WHO has recommended the use of computer-aided detection, or CAD, software programs for the automated interpretation of chest X-ray. This can be in the screening or the triage setting. And this is right now limited to adults aged 15 years or older. Now, what is computer-aided detection for TB? So CAD software are programs that use artificial intelligence algorithms to detect TB suggestive abnormalities in digital chest X-ray images. They do this and then they produce an abnormality score based on what the algorithm detects. And this is typically between 0 or 1 or 0 or 100. And the program then uses a set threshold score, and any abnormality score that is above the set threshold is a signal for an abnormal test result and refers this patient on for further diagnostic testing for TB. Now, why is CAD for TB useful? Why is it now recommended by the WHO? We see that it expands the reach of chest X-ray services now beyond where they might otherwise be available because of the often limited access to skilled radiologists or technicians who are trained to read radiographic images. We also see that CAD can improve upon the inter and intra-reader variability that's inherent in chest X-ray detection when we're using human readers. And we also know that this software brings with it the potential for simultaneous screening for multiple diseases, but we do not yet have evidence reviews on this. We don't have recommendations on this, but we know that we'll see this in the future. And we know that CAD is currently being used in some places to screen for other conditions, including COVID. So this is certainly an area that will only grow. This is just to show that in the guideline development group meeting, we saw evidence that CAD software matches the accuracy, perhaps is even better, but at least matches the accuracy of a human reader. In this data evaluation that we see here, the threshold for CAD was set to establish a sensitivity of 90%, which is the target product profile, minimum target product profile for a screening test. And when the threshold is set to that, we see that the specificity is variable, but is at least equal to or better than a human reader. Now, what I just mentioned, the feature of CAD is that the threshold score can be set anywhere between 0 and 100 or 0 and 1 in the CAD software program. You can see this as a figure on top, from 0 on the left to 100 on the right. Anywhere in that range, the user can set the threshold that indicates when a score is considered abnormal. And there needs to be care taken in how to set this score, because if it is too low, while you will have a very high sensitivity, as you can see on the top bar pointing to the left, you will have a high sensitivity, but you will have an extremely low specificity, meaning that far too many of the people screened will screen positive and have to go on for further diagnostic testing. The algorithm will be extremely inefficient. However, if the bar is set too far to the right or too high, then you will have insufficient sensitivity to detect the amount of TB that you are trying to detect. So because of this, our colleagues at the Tropical Disease Research Program have developed this CAD calibration toolkit. You can see on the screen here. We'll hear a lot more about this today and in later weeks. This is a toolkit that can be used to help implementers determine where this calibration should be set. So with that, I'll say thank you. I'm available for any questions, and I will hand it over to Alexander.
Thank you. Thank you, Cecilie. Greetings, dear colleagues. Thanks for joining this webinar. Before proceeding to the presentation, I would like to once again highlight importance and relevancy of implementation research, especially while introducing digital health interventions, where we will have different type of evidence, and the effect and overall impact will be much influenced by the context in which those interventions will be implemented. This is why it is extremely important to tailor approaches and implementation arrangements to context-specific needs, characteristics of populations, geography, and service delivery settings. This is exactly the area where the data use and implementation research can be employed to inform decisions. In continuation to the previous presentation, I would like to narrow down the focus to the implementation aspects of CAD. And this is especially important as we will break down the sequence and the steps of the implementation. Existing or anticipated challenges will become more obvious, and this will be particularly important to inform implementation research approach and questions and the overall implementation process. And as we go through each of the steps, I would like us to think what would be the challenges and the needs per each of those coming from the country context, since this will be helpful to set the stage for productive discussion at the end of the webinar and in the coming weeks. So let me share the screen now. Right. So do you see on the full
Yes.
screen now? Yeah.
Yes,
Or
yes.
all
Very
right.
good.
All right. So again, over the next few minutes, my presentation will be around two key questions. Like in a majority of interventions and digital health tools, there are two questions. What is this? And how do we implement this? So without further ado, let's proceed to the slides. What is CAT and how it can be of use for national tuberculosis programs has been defined clearly in the previous presentation, and the general benefits of utilizing this technology is obvious, right? But there's another important part of what that relates to the decision of adopting this technology. There's also another part of how question, apart from the implementation steps, aspects, and key considerations, that is how to ensure the effectiveness of this intervention. It is very important to have clear vision of what would be the use case of computer-aided detection starting from the very beginning, the initial stages. Coming from the general understanding of benefits, it is key to understand what are specific challenges that are expected to be addressed with CAT. This not only affects the planning and preparation stages, but importantly defines level of effectiveness and efficiency of the use of CAT technology. And there are still some ways of going wrong with CAT, right? Using it in a very low disease prevalence settings where qualified radiologists available and their workload is not that high, right? So this is, and it is very important to define as much details as possible. We understand that we'll be filling the case detection gaps, late diagnosis, but in which population, in which geographic settings, and in which service delivery settings, whether it be community settings or the public healthcare, so on and so forth. And it's also very important to identify position of CAT in the diagnostic algorithm, not only for the screening and triage part, but also define whether it will be filling the gaps in the human resources or it will be just optimizing the workflow by providing pre-reading assistance or quality assurance. As a part of the how question, the first component here is a situation assessment that is very much linked to the decision-making stage, but with a sharper focus on existing arrangements, such as existing public health interventions, national regulations and policies that are relevant to X-ray systems, levels of integration and capacity of the healthcare system, and also existing infrastructure, technological infrastructure. Here, we can also select possible implementation sites. As for the procurement, it has to be defined what types of the systems are required. They're online, offline, or hybrid. What would be the software licensing terms? It will be per X-ray image read or perceptual license. There are basically two primary sources of procurement. The one is a global drug facility catalog that includes some of the CAT products and also the country level tendering procedures. And depending on the source of procurement, countries might need to develop specifications for the systems that are planned to be procured. Regulatory environment is very important since it not only relates of the registration that might be required depending on the country policies and regulations, but also the operation of the CAT itself, meaning the staff positions and personnel that will be legally allowed to be operated with the CAT and X-ray systems. Another step would be revision of diagnostic algorithms that is also closely linked to the regulatory environment in general. So once the sites are selected, it is important to assess them for compatibility. That's why important to have some sort of checklists on hand that would allow to identify the needs and support further preparations. Standard operation procedures are particularly important, and they can define a broad range of standards related to the CAD system operation itself, but also the data collection standards, quality assurance, reporting, and so on. Diagnostic algorithms and SOPs are linked to establishment and optimization of the patient referral pathways, as it is very important to have clearly defined steps and the sequence of actions, whether it would be for a screening or a triage purpose. And the data systems that relate not only to the data collection and the systems where the data will be stored, but also interoperability with existing TB management systems in country, and one of the key issues that relate to the privacy and security. This is of twofold importance, since it is on the programmatic level, but also relates to the software and the CAD technology itself, since the data is being processed by the software, right? So data ownership, restricted data use, data processing agreements, non-disclosure agreements are one of the key important aspects that should be considered. Revision of registers or any related forms related to the use of the X-ray and CAD, and preparation of monitoring and evaluation frameworks and the quality assurance systems is essential, as well as the human resource planning. Identification of the X-ray technicians or radiographers that will operate with the X-ray systems, and it could also relate to the community level human resource planning. If used for the screening and triage purposes, radiologists here might not be required, since one of the options of adopting CAD technology is the replacement, or not replacement, but the filling the gaps of the unavailability of human readers. Training, the content should be tailored to the stakeholders' role in the CAD project. You might not need actually to come to managers and the program managers with the very technical details, as opposed to the radiology technicians. And ownership, stewardship, and sustainability. As the majority of the CAD projects are supported with the donor funding, it is important to future-proof this approach with the domestic commitments, legal standing, and the national guidelines and algorithms, and so on. So at the end, the key question, how to ensure the operational effectiveness of CAD. Actually, initial implementation arrangements and the way that implementation is planned is a foundation for the success and further effectiveness, as it prepares grounds for effective data use and it informs decision, whether it be calibration, adjustments. It actually sets the enabling environment for implementation research. And since the operation procedures are clear and well established, since the data systems are there in place that ensure that quality data is collected, calibration studies and the implementation research will be well informed and streamlined. So I might expand a bit the calibration issue, that the ability to choose among the threshold scores gives users the flexibility to target divergent program goals, right? So under certain circumstances, a higher threshold score will be selected, resulting in a higher specificity, but lower sensitivity. But under different circumstances, where the priority is to find more TB patients, and there are available resources, CAD implementers can choose a lower threshold score, resulting in a lower specificity, but higher sensitivity. Important issue with the calibration is that it's one of the critical steps in selecting an appropriate threshold score is collection of the local data from the targeted population in a specific setting. CAD abnormality score distribution differs in different populations, depending on a disease prevalence, intervention setting, and use case. And there is no universal threshold score across CAD software, and even within the software versions itself. Well, some manufacturers recommend a default threshold score based on their general experience with the software, but this actually might not be the most appropriate for a given context or the goals of a given program. This way, the key approach here is to conduct on-site calibration studies. Generally, there is a trade-off between the complexity and the method and the accuracy of a selection, right?
Alex, we'll need to conclude soon. Huh?
Yeah, that's the last slide, actually. Yeah. And the last slide here that relates to the implementation research. It can consider any aspect of implementation, including the factors affecting the implementation process and the results, including how to introduce potential solutions into the health system or how to promote their larger scale and sustainability. The intent here is to understand what, why, and how interventions work in the real world setting and to test approaches to improve them. Thinking of a sample question, feasibility, acceptability, and effectiveness CAD and particular population and the public health settings in particular geographic area, so on and so forth. So thanks very much for your attention. You're very much encouraged to check the a practical guide developed by our partners, by Stop TB Partnership that is now available in Russian as well. And you will find the links in the materials. And I welcome your questions. Thank you.
Thank you very much, Alex. Very interesting presentation and additional detail on what we heard in the beginning. Okay, so with that, maybe unless there are questions, and people please do use the chat for questions, or we'll have, I hope, a few minutes at the end to address other issues, but there are clarifications, questions to the speakers. We can try to address some in the chat meanwhile, and with that, I introduce the next speaker, Georgi Kushubidze, who will be speaking about video-supported treatment for TB in the European region. We see the maximized slide. Georgi, it's yours. Thanks. 15 minutes.
Thank you, Denis. So good morning or good afternoon, dear colleagues. I think Denis already talked a bit about the video-supported treatment, but in today's presentation, I will provide more detailed status update on the use of video-supported treatment of TB in the WHO European region. So in the module 4 of the WHO consolidated guidelines on TB, the video observed treatment was recommended the first time as one of the options for administration of outpatient treatment for TB patients. However, this has been issued as a conditional recommendation with very low certainty in the evidence. And we'll get back to this issue of evidence later during my presentation. There is also a technical advisory group for TB in Europe, so-called TAC-TB, which provides technical advice on TB prevention and care to the regional director for Europe. And they recommended the regional office to support the member states in strengthening patient-centered approaches for improving adherence to TB treatment. And the particular focus was on the digital health technologies and digital adherence technologies and the scale-up of these technologies. And in response to this request, back in 2020, we developed a quick guide to video-supported treatment of TB, which answers two main questions. What are the digital health solutions for video-supported treatment, and how this can be used by the TB programs? And we also did an assessment of existing practice of using the video-supported treatment in the Eastern Europe and Central Asia. This is the sub-region with the highest burden of TB. And after the assessment, we provided a comparison of the available video-supported treatment solutions in this sub-region. When we were assessing the practice of using the video-supported treatment in Eastern Europe and Central Asia, one thing became obvious. The tools allowed national TB programs to do far more than just observation of treatments itself. And areas covered by VST includes, but is not limited to, the collection of adverse events data in a way that it allows timely response and management of those adverse events. Connectivity of patients to treatment and care providers, including multidisciplinary teams. Patients can also benefit from digitally delivered information, which is instantly and always accessible through the platform. VST also has the management systems that allow providers to digitally manage their workflows, and tool can be also utilized for provision of support for the associated health conditions that directly or indirectly affect treatment outcomes, TB treatment outcomes. It also has the patient feedback collection features in the form of surveys and integrated questionnaires. And those questionnaires can target the entire patient cohort or a certain group of patients. Community engagement is another feature that could include integrated community messaging modules and so on. And also there is an e-learning component that can also be targeted at various audiences within the platform. So as you can see, this is more than just an observation of medicine intake. It allows just far more. That is why we moved away from using the term video observed treatment and now call it video supported treatment instead. So in summary, video supported treatment of TB allow people-centered service delivery modalities, provide opportunities in resource-limited conditions and during the health emergencies. And the COVID-19 pandemic proved this to be the case. Many countries started using and scaling up the use of the video-supported treatment during pandemic. And last but not least, it became more relevant for TB programs after the transition to the fully oral treatment regimens, as having the injectable agent in the regimen was making it challenging to use the VST straight after the intensive phase and during the outpatient treatment. There are two types of VST interaction: synchronous or using the real-time live video communication between the patient and healthcare provider, and asynchronous, which does not require real-time interaction. And our quick guide is focused on the asynchronous VST and the specialized mobile apps that are used for this purpose. Both synchronous and asynchronous VST can be implemented either via third-party video communication platforms, and we see many countries using tools like Skype, Viber, WhatsApp as an example, or also the specialized application. This can be a proprietary licensed app or customized app, which is developed locally by the programs. And specialized VST software applications require a dedicated system that ensures the secure storage and transmission of recorded videos, and importantly, the compliance to relevant international and national data privacy and protection regulations, which is a very important thing to consider. I mentioned an assessment of the use of VST systems in the selected Eastern Europe and Central Asian countries that we conducted during the development of the quick guide. The assessment aimed to provide a definition of the generic functional and technical properties of the systems in use, and special features and the potential of replication and scalability of the tool. By that time, 3 countries were implementing VST using customized, locally developed systems, and these were Belarus, Georgia, and Moldova, all of which supported the asynchronous interaction. And in the guide, we included a comparison table of these 3 mobile applications. So other countries that were interested could choose from the list the system that they thought fitted their settings the most and the best, and then replicate it to their setting. And on the other hand, we were then supporting countries with all 3 phases of implementation, starting from planning to setup and rollout of the tool and further support of the tool. And all of these steps are described in detail in the quick guide. We also developed a few tools to monitor the progress during the different phases of implementation of video-supported treatment. The replication planning tool, which is an Excel-based tool, allows countries to track the progress at initial phase of planning and setup of the tool. And the M&E framework, which includes a list of indicators, helps to assess the progress during the rollout and implementation of the tool. As I mentioned, the technical assistance was focused on Eastern Europe and Central Asia, given the sub-region is having the highest burden of TB. However, we are ready to provide assistance to other member states in case there is a need and there is an interest from the countries. And you see the status update as of 2021, with countries reporting different level of coverage with VST among patients on ambulatory care. And these are the eligible patients as per the national guidelines. And this range from 12% in Moldova to 57% in Kazakhstan. And the data was collected through WHO survey that we sent out to countries back in December 2021. So as I mentioned, there is a lack of evidence from low and middle income countries with high TB burden on the use of the video-supported treatment. Most cohort studies up to date that we're comparing the VST to the conventional DOT are mainly from the high-income countries. That is why we are developing a generic study protocol for the evaluation of the pragmatic use of the video-supported treatment in the selected countries of the Eastern Europe and Central Asia. We believe this could generate additional evidence from the at least middle-income countries with relatively high burden of disease. The specific aims of the study are to assess TB treatment adherence and clinical outcomes in patients starting TB treatment on video-supported treatment and compare it to the conventional DOT, assess patient satisfaction, treatment-related costs, and VST usability and uptake measures taken by countries, and also to assess the acceptability and scalability of the VST from patients and providers' perspective. So these are the three main study aims of the operational research. And the study protocol is currently under development. This will be followed by the regional workshop, and countries will be offered to take part in this regional implementation research initiative that we hope to launch later this year. This was it for now. Thank you for your attention, and I'm happy to answer any questions. Thank you.
Yes, Georgi, thank you very much indeed. The presentation clear and sharp. Once again, I will try to put in the chat also the link to the guidance that has been published recently, not recently, last year, I think, on our website related to the implementation of video-supported treatment. So if we move on through the agenda, we have Avinash coming and lecturing and presenting us another element, another tool on of the digital technology being used in ending tuberculosis, and specifically in the one of the most impactful operation towards ending tuberculosis, which is prevention. So Avinash Kachar, he is the medical officer in the Global TB program in Geneva. And he is the focal point for the technical area prevention and preventive treatment. Avinash, the floor is yours. And I would kindly ask you to change the display settings in order to go on the full screen. Over.
Okay. Thank you very much, Dennis and Andre. Can you confirm if you hear me well?
We hear you, yes.
Okay.
And we see it very well.
Slide fine now,
Excellent.
right? Okay. Thank you very much for the opportunity. So I will be presenting on the Prevent TB application, which as Andre mentioned, WHO developed a while ago with support from the European Respiratory Society and Digital Technologies. And this application is available on the WHO website. We have provided a link here, but just to alert you that since we have been updating this application, it's undergoing some checks within WHO, and it should be soon available on for you to download. But the application is ready for use, and if there is interest, we can share the links for the demo versions separately. Getting back to what the application offers is the premise was to support strengthen the M&E for TB screening as well as TB preventive treatment in the programmatic settings. And I just have 2 slides, and the rest of the slides are just to give you a glimpse of how the interface looks like. But the first slide is provides you the 3 strengths that the application has, and first and foremost is a smart setup. So the application allows countries or the projects to develop their own mobile application or a desktop version of the application, develop their own dashboards they would like to see to monitor progress in implementation of TB screening, contact investigation, as well as TPT provision. So this smart setup is something that I would talk a bit more, but it gives freedom to you to choose your own data variables to capture, to decide on the data flow, and there are several other things, features within the smart setup that allows, gives you a lot of freedom to adapt the tool for your needs. And then once you develop your own application, you can publish it and visualize it on a mobile device. Could be a smartphone, a basic one, as well as on the tablets. And then we also have a desktop version of the application, so you can also view the variables and all the features on the desktop. And then there is also a dashboard template which offers basic analytics on it, but you could modify, you could add your own analytics that you would like to see. So speaking a bit more about the smart setup, this is how once you if you focus on this bar, once you have a name and logo for your app and register the program, you'll see this page where you can select variables that you want in the registration of the clients. So if it's a contact of a TB patient, then you can choose what variables to capture, like name, age, and gender, and you can decide on the sequence. If you see this last column, you can decide on which variables appears first and which appears later, and you can add different variables that are specific for your country setting. Moving on, and the next one, next tab is for the forms. So you can choose what data variables you want to capture for at different stages after registration. So they may be different for people living with HIV or a contact of a TB patient, or if there's any other target population that you are using for TPT. And then you can follow the cascade of care approach. You can have variables capturing a referral for tests for TB infection, tests for TB disease, and then and so on onto TPT regimens, and then follow up and up to treatment outcomes. So in addition, you can also insert alerts. I mean, at this stage, you are basically creating your own application. So you can put in alerts that you want your healthcare workers to have to reach out to the patients and clients and remind them about certain events. Like if they are referred for testing and if they haven't reached, there is an alert for the healthcare worker to follow up and send the person to the lab for testing. So you can create your own alerts and then also decide on the workflow, as I mentioned. So looking on the left side of the app, you could see there are various other aspects that you can create for your application. Like you can also configure your dashboards. You can decide what indicators you want on the dashboard, what type of chart or display you would like to see. You can generate line lists of all your clients, and also as the one-time activity, you also can decide on users. So what level you want the application to be used? Is it at the facility level, at the community level, and who has access to what data on the interface on the mobile device? So you can do all of this using this smart setup. And lastly, you can also insert or add or delete facilities that you want to use this application at. So it provides all of these features within the smart setup. And once you're done with all of these steps, you can publish this application and view it on a mobile device and as well as on the desktop. Another important feature of this smart setup is also translation. So you can translate it to Russian, or even if there's another local language that you want to use this app with. It's a one-time effort, but you can translate all the labels here and within the app and in the local language and use that in that. So this is how the interface would look like on a on a mobile device. So you have a block for registration. You can view all your clients. You can view the list of all the referred clients for different tests or evaluation. And then also there is a section for alerts on all the pending activities that you want to follow up on. And this is how some of the modules look like risk assessment. Most of the basic elements that you would need for contact investigation are already there. And as I mentioned, you can also change, you can add, you can change the sequence that you want to have. And also on the dashboard, there is some generic graphs and data, but you can also modify this. So this is how you can view the cascade for TB screening, for example. So here you see both the TPT pathway or a TB pathway for a typical contact case. And then of the total registered, how many got screened, how many got referred, and then so on to testing and up to TPT initiation. So you could also map your clients, and there are few more data indicators that you could also add down below on this on this interface. And as I mentioned, you can also have line listing of all the contacts you have screened. And this is one example of the flow that you can create for yourself as well. So this is in brief. You would want to go to the website, try the application out using the demo credentials. If you're not able to, please do reach us and we can share it separately. But it would need, for use in country, you will need to do a bit more adaptation and to your country needs. But there are a few things that I wanted to just highlight regards the technical consideration as well as the data ownership issues. So first and foremost, this application builds upon the DHIS2 architecture, and so it can be easily integrated into the DHIS2 systems if you are developing them, or any other electronic database that you have. This it could be easily bridged, and we can easily connect to your existing data systems in the country. It's open source, so the ownership would be completely with the country or the project, and it can be easily configured, as I said, to adapt to your needs. And you won't need a lot of external support. If you have some capacity within the ministry or within the country, you can adapt the application and you won't need an external support extensively. Regards the data, the app itself, it's compliant with all the global or country security policies, most of them. It can be hosted and deployed on your own servers, and the data is encrypted. There should be no major concerns around security of the data as well. So I'll stop here, and I'm available for any questions, or if there is interest, we would love to work with you in adapting the tool and using your country. Thank you very much.
Fantastic, Avinash. Thank you very much indeed, and especially the dashboards for the cascade analysis and the visualization was, to me, very clear, and I like it very much. So, dear colleagues, indeed, the ePrevent app and the overall platform, the digital platform, is a very much innovation for our region. We never had the register for the preventive treatment and contact tracing, and that might be used widely in the region. We're working now with partners to identify the plans of the implementation, and participants, dear colleagues, please don't be shy and write to us with the requests, wishes, whether you would like to get into the stream of implementation of ePrevent. Dennis, would you like to present the next session? Over.
Yeah, thank you very much. And the next session is about the use of implementation research for digital technologies for TB, and it's going to be presented by our colleagues from the Special Program on Tropical Disease Research and Training, TDR, and that's Vanessa Veronese and Corinne Merle. We already see the PowerPoint, it's in full screen. So yeah, and I think Vanessa is going to present.
Thanks, Dennis.
Yes, we hear you as well.
Basically, these three tools that has been presented to all of you, dear participants, above by our lectors, are to be implemented through through the operational research conditions, and therefore, indeed, the RD for DTB is the tool to be used in systematically implementing and monitoring the programmatic implementation of this intervention. Vanessa, thank you very much indeed. Over to you.
Thanks, Andre. Hi, everyone, and thanks for having me. It's a real pleasure to be able to share with you the work that we've been doing on implementation research for digital technologies. And I'm giving this presentation today on behalf of my colleague, Corinne Merle, and also our colleagues at GTB, who we've worked on to develop this toolkit. Okay. Great. So as you've already heard today, research and innovation is one of the 3 pillars of the WHO NTB strategy. And so this third pillar here includes both the development and the discovery of new tools, as well as research about how to really optimize their impact through implementation. So as we've seen this morning, digital technologies have demonstrated a really significant impact to help further progress towards NTB goals. And as we've also seen, they're increasingly being used by TB programs throughout the world. And since 2007, as you can see here, there's been a range of implementation guidance documents and toolkits published by WHO, which are designed to support the greater use and implementation of these tools within a programmatic context. So despite their wide use, the evidence base for digital technologies for TB is somewhat varied. There's definitely limited evidence related to implementation related outcomes. And in situations where there is really robust evidence on some of these technologies, there are certain factors that are often related to a local context and therefore quite specific that really determine how well a digital tool which may be tested under research conditions will play out in a programmatic environment or in a real world sort of context. So this is the purview of implementation research. It's a discipline that tries to take a systematic approach to identifying and examining various challenges and bottlenecks that can constrain the implementation, the utilization, and the scale up of various health interventions. So in this situation, obviously, those interventions are digital technologies that we're talking about. And so implementation research, after identifying these barriers, seeks to identify and test various strategies that can help overcome these barriers in order to really enhance the effectiveness of these new tools. So this is where our research toolkit comes in. So we developed this. It's an online research toolkit, as Dennis mentioned. It's available, as you can see here, in Russian, in English, and in French. So it's a tool that we started working on in 2019 with our colleagues at GTB. And the overall aim is to really help national TB programs, staff, and other people working in the TB response to develop and conduct implementation research projects related to the use of these new digital technologies in a programmatic setting. So the toolkit, it addresses a demand that came from countries about how to support the implementation of these new tools. And it seeks to sort of build capacity for research, for implementation research, and also to use this discipline to identify how, through implementation research, we can have a better understanding of the critical barriers and factors that can either constrain or promote the use of these tools for TB response. So, as I mentioned, the intended audience for this toolkit are middle and senior level NTP staff and other people working in the space who are interested in innovating within their TB programs using digital tools, but who may require some additional support with conceptualizing, developing, and then conducting implementation research activities. So the overall aim of this toolkit is to provide guidance to countries. And when I say countries, we intend for this toolkit to be used by a study team, so a group of people who will work together on how to develop an implementation research study for use of digital innovations within TB programs. One of the sort of secondary aims of this toolkit is that by supporting countries to conduct implementation research, we hope that we can use the results to really build the evidence base on how to effectively implement these new tools. Right, so then the main output of this toolkit, as I'll explain in a bit more detail towards the end, is a comprehensive implementation research study proposal. So it's quite practically oriented. And the idea is that people can then use this proposal to support their own fundraising efforts. So I'll talk briefly now on how we developed the implementation research for digital technology toolkit, which we call IR for DTB in short. So we adapted an existing toolkit that was developed by TDR on implementation research. So this was a generic toolkit that aims to build capacity to conduct implementation research generally. So we took the principles from this toolkit and we combined it with these 4 core digital functions that Dennis presented earlier to develop the toolkit, which is specifically tailored to digital technologies for tuberculosis. So the website, the online toolkit is organized around the 6 key steps of implementation research. So this follows the same format as the generic IR toolkit that I just mentioned. And so these 6 steps are preparing for implementation research, developing implementation research objectives and questions, research methods for IR, data analysis and methods, planning and conducting implementation research, and finally, knowledge management. So the toolkit is developed around these 6 steps, with each step representing a module that looks like this. So this is a screenshot of the newly developed Russian version. And so you'll see that this is module 1, and the bar across the top, there's a series of subsections with each module that are designed to be worked through in a sequential fashion. And yet the modules can also be treated as a standalone resource. For example, if someone needed support specifically on conceptualizing an implementation research study, but were strong already in the research methods, you could use module 1 as a singular resource. So for each module, there are these subsections I just mentioned, which are linked to very clear learning objectives. So again, this is meant to be a very practically oriented resource that helps build real capacity to conduct implementation research. And so these objectives are also connected to different components of the implementation research proposal. So the idea is that by working through each of the modules, participants will learn various components, and they can use that new knowledge to then develop a implementation research proposal. So we've included in the toolkit a generic template that can be downloaded as a Word version and then adapted and edited by study groups. And then, as I mentioned, used to either solicit some sort of funding or further support to conduct the actual implementation research study. At the end of each of the 6 modules, we've included this checklist that can be ticked so that study groups understand their progress, they can keep track of their progress, and make sure that all of the various components of the proposal have been completed. We've also included throughout a range of reflection activities. So these are designed to be, again, worked through in a group sort of context. And it's an opportunity to reflect on the content of the toolkit and see how it may apply to the specific implementation research challenge or question that the group has developed. The other feature that I think is really interesting is that throughout the toolkit, we've included case studies that we've taken from a range of different countries across those 4 digital functions that we mentioned earlier. And this is designed to illustrate practically how the key learning concepts in the toolkit might be applied in a real-world situation. Finally, we've also included a function. So there's an opportunity to register as a user of the website. It's not obligatory, so you can still access the content even if you decide not to register. But the advantage of registering is that it allows you to track progress, so that if you leave the website and come back, it will take you to where you last were. And you can also see very clearly through the ticked boxes what you've completed and what needs to be done. So just to talk a bit more about how we've gotten to this point. So as I mentioned, the development of the toolkit started in 2019. And then at the end of 2020, we conducted our first pilot workshop with the Chinese CDC and the Chinese Anti-TB Association. And obviously this was in the middle of the pandemic, or the beginning. And so we weren't able to travel. So we conducted it as a hybrid workshop. So there were participants from China who traveled together, as you can see in the photo. So they were together in person, and then we had participants from, I think, 4 other countries join remotely through the week. And so it was a week-long training. And since then, we have continued to provide support to 4 study groups who have gone on to conduct the research that they developed in this workshop. So we've had regular calls since then with these study groups where we provide technical support, we check in and see their progress, and yeah, just see how that's progressing. Right. So as Dennis and Andre have already mentioned, we would love to conduct this workshop now in the Euro region. So we have we've scheduled it for June 13th to the 17th of June. And so this workshop will be virtual. And we've organized it so that there will be daily teaching sessions between 10 and 12 p.m. local time, where participants will receive a range of presentations across the 6 modules. The presenters will be us at TDR, colleagues from GTB and WHO Euro, as well as external participants who have expertise primarily in CAD. And so then after the teaching sessions in the morning, study groups will work with mentors to help who will help them develop their study proposals. And then on the last day, on the Friday, the groups will come together and give a quick presentation of the research proposal that they've developed during the week. So given the interest in CAD, this workshop will focus on CAD as the digital technology of interest. So we assume that people who present will have some experience working with CAD, and indeed the presenters that we have will also have expertise either in CAD from a technical perspective, or they'll have their own implementation experience with CAD. So I think that will be really invaluable to participants to hear from other people who have had their own experiences using CAD. Perhaps most important to note is that there is funding available for approximately 4, though to be decided, study groups who will be competitively selected at the end of the week. And so we'll provide approximately 10,000 USD in funding to enable the study groups to go on and implement the study that they've developed throughout the week. Yeah, sorry, as I mentioned, we'll also be focusing on CAD, and there'll be an opportunity also to provide some training on how to use this toolkit that Cecily mentioned earlier. So this is the toolkit on CAD calibration that we developed, again, with GTB colleagues last year. So finally, how to participate if you're interested. So we will be developing a brief template and we'll send it around after this presentation. We'll also upload a version to the shared drive that I think Georgi posted the link to in the chat. It will be no more than a page, and essentially we would like people to tell us who will potentially be in their study group. And ideally, we would like there to be at least one representative from the local NTP. The expression should also contain a brief description of the current state of CAD implementation in the participant's home country, where it's being used, what point in the algorithm, things like this. And then finally, it would be good for participants to identify some either potential research questions that they may wish to develop into a proposal, or if not, to identify some of the implementation challenges, as Alexander mentioned earlier, that they're facing in their countries and that could be potentially further explored during the workshop and used to start the development of a study proposal. So the expressions of interest will be sent to myself and to Georgi, but keep an eye out for the template that will come later. So that's all from me. Thanks for your attention, and just to acknowledge all the colleagues who have helped in this work. Thanks very much.
Thank you very much, Vanessa. I think that's a great presentation, and with application for the technologies we mentioned this morning and many others, right? And I think it's I think your last slide is very important as well. So last slides are very important because people who want to sort of look further into the use of CAD can join that webinar training on the week of the 13th of June. So I think we're at the end, scheduled time at the end of this session, because it's exactly 1/2 past the hour. However, we had envisaged some time for discussion. I see my colleagues have been very active to reply to chat comments and also provide a lot of more information. We will add more information on the shared site to complement what has been said, but I would like maybe to allow a few minutes for people who want to join. We are still having 71 participants, so it's a great participation. I don't know if anyone counted the number of countries here, but quite a lot from the region. So thanks for joining this call today. But it would be great if some people have comments or want to ask questions, or maybe want that future webinars would have include other sort of technologies apart from the ones that we've mentioned, whatever. And you can ask your question in English and Russian and French if you want, and we can try to address that.
Да, коллеги, пожалуйста, действительно, если у вас есть вопросы, ради бога, включите ваш микрофон, если хотите камеру, прокомментируйте в целом данный вебинар и какие из инструментов вы бы хотели применить в условиях, где вы работаете. И также большое спасибо я хочу присоединиться к Денису и поблагодарить коллег из TDR, в частности Ванесса и Карин, представив данный инструмент для внедрения операционных исследований, используя электронное здравоохранение. Мы просматриваем список, мы не видим рук. Надеюсь, вам это было интересно. Если есть вопросы, пожалуйста, задавайте. Сейчас самое время. У нас собрана уникальная, так сказать, группа экспертов и коллеги из глобальной программы, и мы здесь в региональном офисе, и наши консультанты, и, конечно же, коллеги из TDR, которые также находятся в Женеве, но в данном случае они сейчас в командировке, и большое им спасибо, что они нашли время представить инструмент, даже находясь в командировке. Да, таким образом, смотрите, у нас есть три инструмента. У нас есть CAD, Computerized Diagnosis, который будет поддержан в рамках данного семинара в июне, о котором было упомянуто в представлении Ванессы, VCT, который уже идет, и, конечно же, ePrevent, который начнется, может быть, в середине, в конце этого года, и будет следовать за теми технической помощью, которую мы представляем странам, которые относятся к изменению политик стран и протоколов. То есть вы знаете, что скорее всего, что данный технический стрим имеет место быть в регионе, и после изменения протоколов и политик мы начнем внедрять ePrevent как один из регистров для ведения случаев с латентным туберкулезом. Итак, еще раз, CAD-TB, VCT и Prevent. И все эти продукты в том или ином степени будут поддерживаться через региональный офис, в частности, используя ресурсы USAID, которые были предоставлены и нам, и TDR. Большое спасибо USAID тоже. Итак, мы смотрим еще, я не вижу никаких поднятых рук, либо все было очень понятно. Да, Михаил, пожалуйста, включите микрофон.
Yeah. First of all, thank you very much for organizers of this wonderful meeting. So really, it's very interesting and very important topic. Also in line of the newly designed TB regional action plan for the WHO European region that has been presented last week. But I wonder also in terms of these multiple solutions for different areas, there is also some growing need for a kind of unifying and universal digital health solution. Is there any approach in any direction moving into the let's say a kind of digital health strategy and support to the member states to delivering the overall digital health strategy and actually involving member states into using their own resources, medical institutions, academia, community, civil society organizations, because there is a lot of research capacity already on the ground, and maybe those connections can make the implementation research and actually implementation of innovations a little bit faster. Thank you.
You are muted, Andrei.
Denise, if you could take these questions, Georgi could also add, and if necessary, I can also add as well here. Indeed, digital technology is an instrument to assist and support ending tuberculosis in the region. Back to you, Denise.
Yeah, thanks, Mikhail, for this question. I think it's a very important point, and it's something that a number of countries have been thinking about for decades now, right? To have a sort of overall framework which governs the use of digital technology, not just for TB or even health, but also to go over the whole area of governance, being education, being human development, social service, etc. So a number of countries have taken this approach and are advancing on it. But maybe if we can give some examples, let's say from TB, because probably many TB programs are interested in this and having like a sort of platform which provides for different functions, right, of the that they need. We saw this sort of kind of conceptual framework of dividing them into 4 areas, but a few countries have managed to do this effectively. So, for instance, I can mention, for instance, the Philippines, for instance, is one where they have started with an electronic system for TB patients, let's say in the TB world, and then have built around it a number of other tools to provide for digital evidence technologies, let's say, for dashboards to assess the progress according to some milestones, e-learning, etc. So there are others with this notion, and I think there's some good descriptions of how these could evolve. But I think the main point is really that all the digital technologies that we have, right, such as this Prevent TB app that Avinash has presented, it's important that it fits within the larger sort of landscape of functions that TB programs and other health workers have, and that the notion of interoperability, that means that you have different products that can interdigitate with each other, that can speak to each other, that notion is kept in mind during the development of these softwares, and to ensure that things are sustainable, that they don't need to be sort of changed all the time. I take this opportunity actually to highlight the knowledge sharing platform that WHO has released, which is a sort of one-stop shop for all our guidelines. So the guidelines, let's say, that we've on which we have discussed about video supported treatment, let's say, about screening and use of CAD. You can find them here, but also operational handbooks, and now also tools for e-learning in the training catalog. So those 3 buttons at the bottom. Yeah, I think Askar would want to add more, and Georgi as well. So thanks very much.
Yes, thank you, Dennis. I just wanted also to provide a brief answer to question from Mikhail Volik. Is that the WHO Regional Office for Europe is working under the European Program of Work, and I think it has been mentioned here, and empowering digital health is one of the strategic flagship initiatives. So right now, the WHO Regional Office for Europe is developing the regional digital health action plan for the WHO European region that is covering the same period as the new tuberculosis action plan 2023-2030. And the document right now is under the development, and it will be submitted to the WHO Regional Committee for Europe, 72nd session for the endorsement. And this document is actually that is under the development is developed to support countries to leverage and scale up the digital transformation for better health, and to increase countries' capacity to align digital technology investment decisions with their health system needs. And also the vision of that regional action plan, as what we have been updated by the group in the regional office that is developing it, is to advance this digital transformation of the health sector as a means of contributing to empowering health for everyone, everywhere, and leave no one behind. So there are several important aspects and strategic objections in this document, and hopefully I think that many of the member states already passed through the consultation, open consultation process, similar to what we have done for the regional action plan. Over. Thank you.
Yeah, I also wanted to
Okay,
mention,
yes.
yeah, I also wanted to mention the development of the regional action plan, the information that Askar just provided, just to complement what Askar already said. So there is another group, a big unit in the regional office, which is the Data and Digital Health Unit, and they are the ones who are leading on the development of this regional action plan. But from our side, from TB team, we are also involved in the process, and our colleagues are well aware of those activities and those plans that we have towards using the digital health for TB response. So they are well aware, and we hope that all of those will be also considered in the regional action plan. Over.
Спасибо, Георгий.
You are muted, Andrei.
Спасибо, да. Спасибо, Георгий. Оскар, давайте пойдем дальше. Действительно, тут был вопрос от Аракс касательно, где будут храняться данные при внедрении и превента. Это было обсуждено с коллегами конкретно из Digital Technologies, те, которые разработали, в принципе, данное приложение. Также мы консультировались с нашими юристами и нашими коллегами из ICT. Решение такое. При предложении стране внедрять e-prevent, мы предложим, чтобы страна хостила и хранила данные у себя на территории. Это может быть либо тот же сервер, который используется для ведения электронного регистра в целом по активному туберкулезу, также будет внедряться и будет хоститься электронный регистр для LTBI. Это первый вариант. Второй вариант, конечно же, страна может попросить Digital Technologies хостить в их клауде, в их облаке эти данные, соответственно, Digital Technologies согласны это сделать без каких-либо проблем. Они, по-моему, используются Amazon серверы для этого. Они довольно-таки безопасны. Тем не менее, это должно быть решение страны принято, так как данные будут храняться не на территории страны. И третье, если страна не хочет хранить эти данные в клауде и не имеет возможности у себя это хранить на своих серверах, то ВОЗ инициирует и создаст виртуальный сервер, он будет храниться на территории физических серверах ВОЗ. Мы это проговаривали, и это третий вариант, который предоставляется на выбор странам. Аракс, это был мой ответ. Еще есть один вопрос от Алены из Беларуси. Я постарался перевести. Я думаю, что этот вопрос для Сесиль ответить звучит он следующим образом. То есть, как вы думаете, насколько внедрение КАТ целесообразно в странах, имеющих хорошую развитую систему и службу рентген-службы? От себя добавлю, да, таким образом, Сесилия, я думаю, что вопрос вам, но от себя добавлю, что да, когда-то, когда все ехали на повозках, никто не думал, что машины на колесах или внутренним сгоранием полностью, так сказать, покроет и закроет функцию транспортировки между пунктом А и Б.
Yes, thank you. And I think Dennis mentioned some things in the chat about this question as well. But it is true that the cost effectiveness of CAD, or sort of the perceived utility, will depend on what the existing infrastructure for radiologists and technicians who can read radiographic images is. But it can also provide other important services to a system beyond just replacing a radiologist. So as Dennis mentioned, it can be a useful tool for triaging, such that radiologists can focus their time and mental energy on certain segments of images to be read. It can be used as a tool to help radiologists sort of it can be sort of a double check for radiologists, or another reference that they can use to confirm their readings. And it also can be used in settings where radiologists are not. So if radiologists are focused in healthcare centers and larger hospitals, etc., CAD can also go into the field and be stationed there to allow for some triaging and referral of patients to be sent to other health centers. So I don't know if anybody else wants to add on this topic.
So, thanks very much. I think we are more than 15 minutes late from the scheduled time, and yeah, still a lot of participants here, and thank them very much. Again, if you want to join the workshop, please send us your participation, small sort of document to express what you want, and then we can include you. It is free of charge. It is like we'll have about 2-3 hours per day on consecutive days throughout the week. So you'll need to devote time to it, of course, those who want to participate. But from our experience, people usually participate and are very enthusiastic to see this. So please do apply. With that, maybe I can thank every speaker today. I thank you, Ro, for organizing this and for helping us to spread more knowledge. This is great. I think TDR as well. I think the donors as well for making this possible. And again, I thank you for spending this time with us. And I pass over to Andrei and to Oscar if they want to say something.
Спасибо, Денис. Действительно, большое спасибо лекторам за то, что они смогли найти это время и предоставить вам эту информацию. Я также хочу добавить, что мы первый раз попытались стримить этот самый вебинар, то есть вы сможете после этого просматривать и вспомнить те или иные, так сказать, стейтменты, которые были сказаны здесь. Опять же, хочу подчеркнуть, что есть полностью переведенный сет презентаций на нашем репозитории, который был вами выслан ранее. И да, вот переходим также для e-learning на виртуальные и электронные здравоохранения в том числе. Оскар, слово вам для заключения.
Спасибо большое, Андрей. И на самом деле видится большое будущее за внедрением цифровых технологий в здравоохранении, в частности в туберкулезе, во всех его направлениях. И хотелось бы отметить, что на самом деле для нас это является приоритетом в наших странах европейского региона, где уже происходит активное внедрение цифровых технологий во многих технических направлениях туберкулеза, значит, использование его в дополнительных направления, такие как профилактическое лечение туберкулеза, систематический скрининг, только добавит, значит, и ускорит наши темпы и попытки достичь целей, которые мы ставили перед собой по снижению времени туберкулеза. Мы это активно прописали в нашем новом региональном плане действий. И это поддерживается соседними, как я уже говорил, другими планами, другим планом, который разрабатывается региональным офисом по цифровому здравоохранению. И мы надеемся на то, что страны найдут в себе силы и возможности и при поддержке международных партнеров, доноров, для того, чтобы развивать это направление. И этот вебинар, как бы он является вводным для последующего, значит, внедрения и поможет вам в расширении этого доступа. Спасибо.
Всем позвольте откланяться и пожелать всем хорошего дня и хорошей недели. Увидимся, да, на полях и либо в облаках нашего виртуального пространства. Всего доброго.
Bye. До свидания.
Bye. Thank you.